Good afternoon. On behalf of the Florida Department of Health and Volusia County, welcome to the final 2021 Path for Hope Virtual Summit Plenary. My name is Helena Gerard, and I will be the facilitator. You have joined the session entitled Opioid Use Stigma in Healthcare Providers, Key Concepts, Where We Stand, and Future Opportunities. This session is being recorded. All participants will be muted during the session, though there will be question and answer time at the end of the session for you to pose questions. You may raise your hand using the reaction button at the bottom of your screen, and then we will call on you and allow you to unmute yourself. You may also submit questions during the presentation in the chat box, and we will pose them to Dr. Yang at the end of the session if time allows. Thank you to the Path for Hope Summit Planning Committee partners, Advent Health, Community Coalition Alliance, One Voice for Volusia, SMA Healthcare, and the Volusia Recovery Alliance. It is my pleasure to introduce Dr. Larry Yang. Dr. Yang holds a doctoral degree from Boston University in clinical psychology. He was awarded a clinical fellowship at Harvard Medical School to work with the Massachusetts Mental Health Center and has received 8 early career awards for his work on stigma, 6 of which are national. Larry is a member of 2 prestigious editorial boards, the Cultural Diversity and Ethnic Minority Psychology Board of the Journal of the American Psychological Association and the Stigma and Health Board of the Journal of the American Psychological Association. He has also authored publications in the Lancet, British Journal of Psychiatry, and the Journal of Abnormal Psychology. Welcome, Dr. Yang. We are so excited to have you here. Thank you so much.
Thank you so much, Helena, and real pleasure to see everybody today. Wish we could all, of course, be in person, but we'll make do with what we can. So let me dive into my presentation today, which I will hope to really engage you all in this very thorny issue of opioid use stigma. So let me start it from the beginning. Let me see. Okay, can people see my screen? Helena, can you give me a thumbs up?
You are good, thank you.
All right, excellent. So thank you, first of all, for this gracious invitation from the folks at Volusia County. Really a pleasure to work with you on this difficult issue and have the chance to present to you today. And so I'll be talking primarily about opioid use stigma in healthcare providers, where we are, what kind of work we've been doing in this area, but I'll be folding in quite a bit of other work as well. Other stigma from other stakeholders as well, as you'll see. So just a tiny bit on my research background, and this is, Helena mentioned quite a bit of it. I think the key takeaway is that I've had a long history of stigma work in mental illness and psychosis, and NIH funding to support this work. And essentially, stigma has really had its roots in, well, first of all, racism. Research on racism, but then also research on how to decrease mental illness stigma. More recently, HIV stigma has become, is an area of pretty mature research. But most recently, it's really now extended over to opioids, and that's basically how my own research trajectory has evolved. I published a number of papers on stigma, and I led this stigma measures review for the National Academy of Sciences, and also worked with peers in terms of to develop stigma interventions. Today, I will be informing my talk with some other work that we're currently doing with CDC and NACCHO and the New York City Department of Health and Mental Hygiene, NYC DOH, MH, are really great partners in this work. So an overview of today's talk, I'm going to be touching upon different sources of opioid use stigma, because these actually play quite a role in healthcare provider stigma. So this includes public stigma, self-stigma, and then stigma among healthcare providers. I'll then talk about how stigma in health facilities looks. It's a complex problem, it's a complex issue. And I want to give you, as much as time allows, a real, in-depth view into it. And so stigma towards medication-assisted treatment specifically, I'll touch upon structural factors and then what is happening in terms of interventions. So the main sources of my talk today are, again, drawing up quite a bit upon reviews of applications of mental illness stigma to substance use related stigma, Pat Corrigan has really led the charge in this, a renowned stigma expert. And also, again, growing, scientific literature around opioid-related stigma reviews. And, myself, I've contributed to this literature as well. There's also been progress in the stigma field generally, just through, national funding agencies are really interested in tackling this issue. And again, I'll be informing this with learnings from projects that I've been engaged with with CDC and NACCHO. And these will actually be marked in purple, so you'll be able to tell, what is ongoing work. So in terms of some of the concepts I'm going to be talking about today are really embedded in this figure, and I'll return to this at the end of today's talk, but we can really understand this all to start. Well, let me start with public stigma. I'll define each one of these in turn, but this is obviously community perceptions of stigma towards people with opioid use issues. Self-stigma, so what are the folks who have this condition experience, and then stigma in health facilities. And you'll see, I'll make the case for these things all being intertwined. These things all fall underneath structural stigma, or the overarching policies that are present, regarding opioid use disorder and treatment. And we'll be filling in, I'll come back to this figure at the end of the talk, and we'll fill in some of these bubbles. Before I jump into each one of these forms of stigma, though, I really want to start with this very, very influential theoretical stigma model. Won't make it too fancy. I'll tell it like a story, which I really think it's best really explained as. So what you can see here, this is actually the modified labeling theory proposed by my dear mentor, Bruce Link, at Columbia. And you can see here, he actually proposed it for mental illness, but it's quite applicable to opioid use disorders and opioid-related issues. So let's go through each step. And like I said, I'll tell it like a story. So in step one, you can see here that we all grew up in a society. Each society has conceptions of what it means to have, in this case, so let's replace mental illness with opioid use, related problems. And there are perceptions of, basically, what do people think about people who have issues or problems with opioids? And this is usually, I call an audience participation here, but I will, throw out some of the really unfortunate and regrettable stereotypes that we really have to counter for folks who have opioid-related problems. And these include being dangerous, irresponsible, immoral, et cetera, et cetera. I'll get into all of those in just a little bit. But unfortunately, society holds these stereotypes in quite strongly. So let's go down this path, the bottom path here. So let's say you're fortunate enough never to have any issues with opioids, or might look like you have issues with opioids. So in this case, you're not labeled, quote unquote, with having an opioid use problem. And so you're aware of these societal conceptions, sure, okay, I'm aware of what people think about people who use opioids, but they're not relevant to who you are, and there are no consequences to the labeling. So that's where this bottom path ends. So let's go back up to the top path. Let's say that you have had, you're starting to use opioids and you're starting to have some problems with it. And let's say then you go into treatment. And this is actually the real pivotal piece here. You go into treatment, and let's say you even accept, MOUD or different forms of treatment. And I'm sorry, I should have updated it. So sorry. I think now it's MOUD instead of MAT. So please forgive that oversight. But that acronym keeps changing. But as soon as you accept treatment, from a licensed provider, then all of a sudden these labels become relevant to who you are, right? So all of a sudden you might become aware that, oh my gosh, if I go into work, so-and-so is going to think that I'm dangerous and I'm irresponsible and that I'm, immoral. And so what happens then is a cascade of negative events. So as these conceptions become relevant to who the person is, the person may then react with secrecy and withdrawal, right? I'm not going to tell this about other people about the status because it will trigger all these negative reactions. And then because of this, because people are secretive, maybe they will, choose to no longer work, or not go for, to start school, or to basically forego life opportunities. This has negative consequences for self-esteem, earning power, social network ties. And then these cluster of negative psychosocial events may then lead to vulnerability, the last step here, in terms of, okay, well, that may trigger even more opioid use or other problems like depression or other mental health problems. One other thing about this model, which is very important, it really suggests where we could actually do some intervention. Number one is that we could try to change stigma at the societal level, which we should. We absolutely need to. It's slow. I'll get into that in a second. The second place, though, logically, is when people enter the treatment system. This is when the labeling occurs. So what can we do to mitigate the negative impacts of this label? Because, of course, labeling also has positive effects, because then it initiates opioid-related treatment so that folks can, help to manage this condition, and then, just hopefully move towards recovery. So again, the second step here is crucial in terms of thinking about the health facility system and when folks come into it. So just to go through some of these precursor concepts that, again, I'll make the case to you that are really bound up with healthcare provider stigma. So public stigma is the process by which general public stigmatizes individuals who use opioids, which consists of processes of stereotyping, prejudice, and discrimination. So this is the most researched form of stigma. There's a lot of work on it. And basically, as opioid use even though opioid use is becoming more and more common, the public stigma towards it persists. I want to introduce this concept. I'll touch on this throughout today's talk, this concept of intersectionality. It's not going to be the focus of my talk today, but it's critically important. Basically, how multiply marginalized individuals are most affected by opioid stigma, and I'll get into this in other slides. But there are core pervasive negative stereotypes that are identified in the literature. These include dangerousness, irresponsibility. I have an asterisk here because it really plays an important part of, in the rest of my presentation. Criminality, being untrustworthy, hopelessness, worthlessness, being lazy and weak, and blameworthiness. And the underlying judgment here, unfortunately, again, is that opioid use signals immoral behavior in some way. So as an example of the work that we've been doing in one of the sites that we've been, I've been assisting, is in Marion County. So here, what they did was they did a representative sample of 600 community members that they ascertained at 2 different time points, so 12 months apart. And what you could see here are basically these societal, that's step one, the societal conceptions of what it is to have an opioid use problem. So here, I'll review the question. In your opinion, how likely is it that a person with substance use disorder, in this case, it's substance use disorder, cannot be trusted? And you can see here at the first time point, 83% endorsed this item. And then second time point, 12 months later, it just dips just a tiny bit, 79%, but it's very, very high. The second item, in your opinion, how likely is it that a person with substance use disorder would do something violent towards other people? And again, you see corresponding rates of 76 and 74%. The take home is that public stigma, this is in Indiana, so different in different locales, of course. However, I'm fairly confident. Number one, public stigma high. Number two, unlikely to change unless without concerted efforts. It's going to stay pretty high in all likelihood, unless we do something to alter it. In terms of self-stigma, so the second big concept. So internalized stigma and self-stigma takes place through stigmatized individuals themselves once they become aware of stereotypes and apply the stereotypes to themselves. Oh, so I should have noted this. During the modified labeling theory, you may recall, right, that when the person is identified with these with the status, and then they apply the stereotypes to themselves, that's when all the negative consequences could occur. So to be explicit, nobody has to actually treat the person in a negative way, you'll notice, right? It's simply that people could treat you negatively, and that would make things even worse. But just the mere fact that you're identified with this status and that there are so many negative conceptions of using opioids in society, all these negative things can happen even without anybody treating you in a negative way. So internalization of public stigma occurs, and the people who have used opioids then again have these really regrettable feelings of self-blame, self-loathing, despair, shame. Pulled some quotes here for some articles. They've permanently screwed up their lives and they have no place in the world. And this is reported by all types of opioid users, not just people who use illicit opioids like heroin and fentanyl, but also primary care populations and people who use, MOUD. And there may be higher self-stigma associated with the use, again, of medications related for opioid treatment. And this is, again, possibly due to these labeling effects, right? Because if you're taking the medication, that must mean that you really have some kind of opioid use issue that requires this level of treatment. So the impacts on the individuals are pretty strong. And so obviously it could impact negative psychological well-being, as I spoke about earlier. There could be this looping effect, which is really talked about in modified labeling theory. Well, because if all the negative emotions that come up, the people may actually then utilize opioids in order to cope with those negative emotions. So it precipitates more opioid use. This is an obvious and big problem, accessing illicit drugs instead of medication treatment. So obviously going out on the streets, heroin, fentanyl, etc. And then it also becomes a barrier to treatment, which I'll talk about in a second. So the stigma related to treatment. All sources of stigma present a barrier to engagement in, again, medication treatment programs. There's the belief that people who perceive medication treatment are simply replacing one substance with another. And this is, again, this notion of, well, basically you're still, you're not doing anything to quote unquote fix the problem. You're just basically switching dependency from one substance to another. And so methadone is associated with even higher stigma because it's more well-known and it's associated with heroin use. So again, for the folks who are entering into treatment, they want to obviously avoid these labels of using basically dependence, so to speak, and being identified as someone who could be seen as an addict or a junkie. And this could lead to secrecy and treatment and lack of treatment initiation. Among chronic pain patients, this is also an issue. So there's a fear of stigma that is associated with the label of quote unquote being an addict. And those who do use medication treatment report feelings of guilt and being morally weak. Let me return to this concept of intersectionality again, just because it's a really critical one. And there's not enough that is really understood about this yet. That self-stigma and its negative impacts can be compounded and or reshaped by other intersecting identities. And these can include things like race, gender, other substance use. And these statuses could then increase stigma's impact and decrease the likelihood of seeking treatment. So this includes, again, being a racial ethnic minority, being duly diagnosed with depression, for instance, if you have HIV or engaged in sex work. Also, for women, being mothers and survivors of sexual violence, unfortunately, also could compound opioid use stigma. Okay, so just take a breather for a second. Covered a lot already. Talked about public stigma, talked about self-stigma. Now I'm bringing it home to stigma in health facilities. I'm going to stay the rest of the talk. So stigma in health facilities negatively affects people seeking health services and ranges from denial or provision of substandard care, again, for people within the healthcare system, to more subtle forms where the person is treated as having a lesser status. So it could be stigma and discrimination can be overt. It could be much more subtle. The attitudes that exist among healthcare providers, again, unfortunately, is commonly there's a suspicion towards all people who use opioids, regardless of whether they're legal and prescribed or illicit. And so these stereotypes, again, abound, unfortunately. The same stereotypes that exist in society, unfortunately, also exist among many healthcare providers. So junkie, drug-seeking, manipulative, dishonest, and difficult. And again, these attitudes can exist in greater or lesser form, but any of these can impact treatment. So some providers, for instance, the more extreme versions could withhold or drop clients because of their opioid use. Some providers also endorse mandating coercive treatment. We found this in a review among people who misuse substances. All right, so I'm going to pause here for a moment, and this is where I'm actually going to ask the technical folks. I believe we can do this. So I've got a question to elicit some audience participation, and let me read it to you. What forms of stigma are related to healthcare provider stigma? And here are your possible responses. A, public stigma. B, self-stigma. C, labeling process of self-stigma. D, healthcare professional stigma. And E, all of the above. So can I get some help from our tech people? I believe we can do a poll.
We can. It'll just take me a second to set up, but I'll do that right now.
All right, thank you. Thank you. So you all can just take a breather for a second and ponder this question. Okay, is it almost there? Great, thank you so much. All right, I see people typing in their answers. Thank you so much, I appreciate it. We're at 10 of 24. All right, I'll give you about just 20 more seconds. I think we've got 16, 17 participants. All right, very good. So let me, so thank you so much. That was, I'm glad that, thank you all for participating in this with me. So let me just, I'll share the results with all of you. Oh, actually, I think thank you for sharing the results. So I'm glad that, that I successfully built the case. I think for most of you, 15 out of 17, 88%, see all of the different processes of stigma as that I've just described as really feeding into healthcare provider stigma. I do agree for the people who did say A and D, I also do agree with you, public stigma is the root of it. And then D, obviously, healthcare professional stigma is obviously associated with healthcare provider stigma. So thank you so much just for this. But this is just really to underscore, one of the main points, and that is that the society-wide stigma, really, the healthcare provider stigma is a symptom of the society-wide stigma. So let me continue on. Thank you so much for that. So in terms of intersectionality, and again, there has been growing research in this area. This affects physicians' treatment once the patients are in treatment. And so, for instance, for Black and Hispanic and Latinx patients who have opioid use problems, they are even sort of doubly stigmatized because of this, because so they suffer being under or mistreated for pain. They also experience being less likely to be prescribed opioids than white patients. Higher rates of drug testing, even when they enter treatment. Referrals to pain specialists versus actually getting into a substance use program, and also have differential OUD treatment discontinuation. So let me move on to some of the work that, again, that I've done in partnership with DOH and the different DOHs actually, some around the country. And so there are two projects I'd like to highlight. Number one is work that I've done in Tarrant County in Texas among a health department, and going to illustrate use of this tool that we developed to look at really stereotypes, and this fancy term semantic differential, but really you can just think of it as stereotypes. And then I want to get into some qualitative work using focus groups of healthcare providers and in-depth interviews for people who've used opioids. And this is work we've been doing in New York City. So in terms of the semantic differential, there are 21 contrasting adjectives on a semantic differential rating scale. I'll show you what these are in just a little bit. But basically it ranges from -10 to +10, and then 0 is the midpoint. And what we did was we drew from 9 different studies and reviews, again, discussing the types of stereotypes that are really common. And these include dangerousness, criminality, and untrustworthiness, hopelessness and worthlessness, being lazy and weak, and then blameworthiness. In collaboration with one of the sites, we also developed novel social determinant items. I'll describe what those are in just a little bit. And so what happened was we had the opportunity at this local symposium on opioids, and it was primarily in Tarrant County in Texas. We were able to actually administer this, measure of stereotypes primarily among healthcare professionals. It also included things like elected officials, prescribers, emergency responders, law enforcement, and social workers. And the total sample is 236. And so anyhow, we can use this, what's nifty about this tool is that it can be used among any stakeholder group. So this is what it looks like. So again, there are a set of polar adjectives, 21 actually, and they're basically opposite. They range in opposing adjective pairs. So here you can see morally weak, morally strong, intentional, unintentional, not a real illness, and then lazy and self-disciplined. And participants are asked to indicate what most people in your profession think about people who misuse opioids. And we ask this in this way because, people know what to say when you ask themselves what their attitudes are. But if you ask about most people, what do most people in your profession think? Well, that might help to get around some some sort of self-report biases. And so what happens here is that 0 is actually the midpoint of these dashed lines, and it ranges from -10 negative and then +10 positive. And so then we're able to count up where the responses are, and you can see where it falls, positive or negative. What's nifty about this is that, so we utilize, out of, again, primarily healthcare, providers who came to this, professionals who came to this conference. We pulled together a word cloud, and you can see here, and you can see some of the main adjectives that popped out of the 21. So there's some positive findings here. Number 1, treatable, real illness. So that makes sense, thankfully, because they are primarily healthcare providers. They did see the opioid uses disorders are treatable. But you could also see a cluster of negative stereotypes. These include things like irresponsible, deceptive, lazy, and dependent on others. So you can again see, unfortunately, a negative cluster stereotype also. So what we were able to do is we use this statistical technique. It's called exploratory factor analysis. In short, what it does is it enables clustering of different concepts. So from the 21 adjectives pairs, we actually were able to distill 3 clusters from these adjectives. The first includes this first cluster of upright citizen. And I'll give you, there are 9 adjectives here, and these are sort of the exemplar adjectives that a person is responsible, truthful, and upholding society. The second cluster is that around socioeconomic resources, so 5 items. This is the socioeconomic disparities piece that I was talking about. So a couple of examples here include high income and being employed. And then the third cluster includes legitimate illness. So is it a real illness? Is the person a legitimate patient? And there are 6 items. And then what we could do is we could see actually how do people fall in terms of high or low on these 3 clusters. And confirming what you saw in that word cloud, what we could see here, first of all, there was a pocket of strength that people did tend to see it as a legitimate illness. So the mean score fell on the positive side. Again, it ranges from -10 to +10. It's a +1.7. 26% of respondents rated significantly greater than neutral. So signaling that, okay, well, people were more likely to see it as a legitimate illness than an illegitimate illness in this cluster, which is good. Unfortunately, though, the negative finding is that the respondents were less likely to see folks who have opioid use problems as being upright citizens. And 38% of respondents actually rated people significantly lower than that middle neutral point. And the mean score in this case, it makes sense, is negative, -1.7. So, and then to round things out, in terms of socioeconomic resources, it's actually very close to the midpoint, -0.7. So it wasn't, it was a little bit lower than neutral. People tended to be a little bit lower than neutral, but not, so much. So, but really the stronger findings were in factors 1 and 3. So what's nifty again about this is that we can use the results then to develop potential campaigns and education materials to mitigate stigma related to opioid misuse in healthcare providers. And upon reflecting upon this with some, with an opioid use provider expert, a way to really devise a message that really syncs up with these findings would be that we could leverage knowledge of opioid misuse as a legitimate illness. And then the development of biological response to opioids, right? Because it's basically, right, people in the beginning may choose to take the opioid, for whatever circumstance or not, maybe they're prescribed the opioid. But then after they've taken it for long enough, what happens is there's a development of a biological response. So it's a legitimate illness, it's a biological response. This is to remove the perception of irresponsibility, which is really core to this whole piece around upright citizen. So you could see how we could utilize these stigma findings to really inform a messaging campaign towards healthcare providers in a way that really coheres with their understanding of the illness. Let me continue on and talk about what's known and not known, or what's known, and then, how we further illuminated this through our work. So in terms of stigma in health facilities and its impacts on clients, what's known in the literature is that there's a low level of trust among people who use opioids and healthcare providers, and this leads to worse outcomes among the patients. Healthcare providers, again, often describe these individuals as difficult patients who use opioids as manipulative, dishonest, demanding. Talked about this earlier. Correspondingly, if the healthcare professionals, endorse these stereotypes, then clients are very, very sensitive to this. They're sensitized to this, actually, because again, they're aware of how other people think about them. They're very aware of how physicians might think about them. Many of them may have been treated badly by physicians by the time they come in to see a new physician. So they feel they're being judged, mistreated, and receive unequal treatment from physicians. Our qualitative work in New York City has shown that multi-level factors contribute to these communication breakdowns. I'll get into this in a bit, between providers and patients. And so what the core dynamic that we found was that there's a lot of frustration for both parties. Patients don't feel like they're being heard. Docs don't feel like that their message is being heard. This then leads to lower quality care and enacts further stigma. So just a note here, and this is very, very important, and this is pretty clear from the literature and just the work that we've done with a bunch of the sites, that healthcare providers, in addition to stigma, the stigma also comes from the fact that a lot of healthcare providers just don't feel like they've had enough education and training in the course of their, in the course of them becoming providers, because dealing with substances and opioid use is really a specialized area that not a lot of providers have, access to. So a lot of folks don't feel like they have adequate education and training and have a lack of confidence in this knowledge. And they feel that stigma limits their involvement in administering medication treatment. And this also, because it could be judged by other folks in the medical community and other patients, right? Quote unquote, they don't want, quote unquote, those kinds of patients and they're like sitting in the waiting room and that sort of thing. Those are the kind of, stigmas that are reported by physicians. Most medical patients feel they have insufficient education regarding opioid-related issues, and interventions also, while addressing stigma, I think really, in order to work in these health facilities, have to also work towards increasing education and comfort level. This is almost the preceding, or really hand in hand with, tackling stigma and attitude change. So some of the key messages that we've did, so we interviewed a set of providers, I can't remember, it was around 15 or 20. They're primarily actually residents in these different hospitals in New York City. And then we also interviewed a set of folks who with lived experiences with opioid use. And what we found was that were these key messages that we distilled for use in this video that we're developing for medical trainees now. People are legitimate medical patients who are worthy of the same quality of care. That OUD is treatable. Patients with OUD can be effectively identified, assessed, and referred. That remission or recovery is possible. Language that healthcare providers use with patients with opioids is extremely important, can have a significant impact on the experience of care and overall treatment trajectory. And then again, coming back to this piece, that there is a breakdown in communication. What ends up between the provider and patient. So what ends up happening is that the patient comes in, their number one priority is to relieve a lot of times, the discomfort that they're in. It could be withdrawal symptoms, it could be, but they're really seeking immediate relief from this discomfort. And the docs, have their own set of priorities. They're oftentimes thinking about, well, there's this, medical condition or some other issue that is really sort of the underlying root of what's bringing the patient in. And so the two are not really communicating about, the same issue. And so what ends up happening is there's this, again, this breakdown in communication, but that there are strategies that can be used to address this. And a lot of this is around the docs really meeting the patients where they're at and really, taking a sort of checking, in a sense, their priorities and really sort of more prioritizing what the patient needs in that moment. So non-stigmatizing interactions with providers can make a significant difference in people with OUD's overall care. And the trick, again, is to get the folks to come into treatment, get engaged, build trust with the provider, and then hopefully over time, you can work on these opioid-related issues. Easier said than done, I realize, but that is a path forward. So let me just wrap up by talking about structural stigma. I'd be remiss if I didn't touch upon this. These are institutional practices that work to the disadvantage of the stigmatized group or person. And here, what you see here, what's going on here is that there's, right now, because of the over prescription of opioids, now there is what is perceived as excessive regulation in prescribing opioids that increases bureaucratic barriers to access to care. So basically, because the docs have trouble, right, more trouble prescribing because they have to justify, essentially have limits, etc., then that really spills down to the patients. They feel that, when they're trying to get this medication, which they feel like they, need, that that they experience, basically, restrictions in this, and then they feel like, I'm not being treated like other patients, right? Why am I being subject to these what feels like unfair restrictions? And these stem from the policies that are aimed at curbing improper prescribing. And then there are a host of other ongoing policy changes. This is being changed now. There's an elimination of group waivers for physicians now. Nationally, as I understand, there are ongoing treatments and changes in treatment systems, many of which you all are engaged with and which are really fantastic. Continuity of care and integration of OUD treatment into primary care. And then there are contextual things that might be occurring in the community. So increasing access to harm reduction, like syringe exchanges, those are possibilities. Well, all of these structural changes also inform the kind of stigma that's experienced in the healthcare setting. So our qualitative work also, and I really, what really came very clear as well when we talked about health facility stigma was that, yes, it's true, the docs, hold negative attitudes, that's completely possible and, sometimes likely. There are, however, these really powerful contextual factors that are at play as well that constrain the doctor's, basically options. Because these structural level barriers actually manifest in clinical interactions to impede quality care. And they look like this. Basically, traditionally, there's a separation of OUD treatment from primary care. The treatment around OUD is not well integrated into people's training. Time as a provider, as many of you know, is scarce. Providers are busy. They don't necessarily have time to be empathic, and it more easily leads to frustration. And then there's a variety of other barriers ranging around confusion around insurance to shortages of outpatient OUD treatment programs. A couple great quotes from some of the docs we spoke to. This is actually a resident. More than the general frustration of being an intern or resident being pulled in 3 different directions at once, not unique to patients who are addicted to opioids. That's just a hospital thing. It's a condition of being an intern or resident on the medicine service. So they just don't feel like they have the time to provide, even if they wanted to. Another doc says, nothing streamlined. Why don't these people talk to each other? Even though they're supposed to talk to each other, like the pharmacy and the doctor, all that, but it leads, because there's not this coordination of care, it leads a lot of it up to the patient. So again, these structural level barriers really impede quality care. And for the patient, it ends up feeling like, right, they're being neglected by the doctor or by the system. So let me return to this, this chart that I had in the beginning, and now we've filled in the bubbles through this talk. So we've got the structural stigma and the policies, which I just talked about. In terms of public stigma, just some takeaways. People want to avoid the label, right? They want to avoid the label of misusing opioids and all this negative stereotypes. So this decreases their likelihood of engaging with services. In terms of self-stigma, if they do make it into treatment, there are all these negative consequences, shame or psychological well-being. There's the possibility of decreased engagement with OUD services and then correspondingly worse outcomes. And then the stigma in health facilities is manifested, first of all, that even using prescribed medication treatment is the moral equivalent to illicit drug use. There's a perception of irresponsibility and immorality, and again, differential treatment of OUD patients by the docs, whether conscious or unconscious, also again, abetted by the policies and structures that the docs are working in. There's a communication breakdown that occurs between the doctors and patients, very easy to happen, that then contributes to stigma. And again, all of this then contributes to decreased identification or referral to OUD services. So I just want to end, at least on a little bit of a hopeful note, and that's interventions. This is a problem. Let me just come back to this for a second. I know I threw a lot of concepts at you today. I'm giving you a deep dive because this is not a simple problem, and there are no simple solutions to it. But I think that accurately diagnosing the problem and all the different contributing factors are really, really important to really devising an adequate solution. So I hope that you're able to take away some of these key points, and hopefully it will help to inform just your thoughts or engagement with in these issues, in the coming days and years. In terms of interventions, we have so there are two major types of interventions that occur to address stigma. One is education. This is what you think it is. It's educate around the condition. You educate there's treatment. You basically, say that it is treatable. This is where you get treatment, et cetera, et cetera. That does help to reduce stigma. The contact-based treatment stigma approach is basically interacting with folks who have the condition, who have recovered, and who are able to talk about their experiences and humanize it. The two together tend to work the best. This is true for mental illness. Less known, we think it should work for substance use disorders and opioid use disorders. We have every reason to believe it would, but it has not been rigorously tested yet. And folks are in the midst of doing this. In terms of the existing interventions that do exist, in public stigma, again, combined education and contact for people who have substance use disorders. And this is, for instance, New York City's DOHMH has done a great communication campaign around this, Living Proof, probably the best example of it. Self-stigma interventions, the few that exist, and the ones that do exist are built into residential treatment programs or group-based and built on, for instance, ACT, acceptance and commitment therapy, or mental and stigma interventions. And then I have here outlined in red that in terms of provider stigma programs, these are largely brief training modules that are integrated into medical training or continuing education. Some use contact-based approaches, so basically interacting with folks with OUD. But to date, these have been rarely specific to OUD, mostly addressing substance use disorders generally. So again, this field is new and emerging, and these types of stigma interventions are really being tested now, and hopefully will be proliferating in the years to come. So I want to thank you all so much for your attention. Again, I know I took you through a lot of stigma concepts. I also have this set of references just for people if you are interested in learning more, but I will stop sharing for now and open it up for questions.
Thank you so much, Dr. Yang. That was amazing. Definitely a perspective that I don't think we often get a chance to dive deep into. So thank you very much.
Pleasure. Well, you're all on the ground, and I know you'll have the chance to do something with this knowledge, which is exciting to me.
Absolutely. All right. If you have any questions, I know we're at time, so if anybody has any questions, feel free to email me and I can send them over to Dr. Yang. It's been an absolute pleasure working with you. Thank you so much. Attendees, please use the link in the chat to complete your evaluation survey for this session. Thank you to Florida State University for managing the summit evaluations. Thank you all for participating and making this possible. Please go to your summit program or visit pathforhope.com/summit2021 for the link to the next session. And in the chat, it's saying wonderful. I agree. You're getting some very good comments. So thank you so much, Dr. Yang.
Real pleasure. And we'll be in touch shortly. Best of luck exactly with everybody with this work. And we're all pulling in the same direction here.
Thank you.
Take care now. Bye.
You too. Thank you.